The following was recorded at the CCHF Conference 2023 in Cincinnati.
Well, I'll go ahead and introduce myself. My name is Myles Adamson. I'm a family nurse practitioner. And just very excited to be able to present this topic to you this afternoon. I am also just thankful, and so thank you for coming. This is a topic that's just very close to my heart, very close to Summer's heart, and we're just excited to be able to share a little bit more about the way that God has been working through our clinic. The clinic that we work at is Hope Christian Health Center. We're an FQHC in Las Vegas, Nevada, and I am the outreach director, which means my sole purpose is looking for ways that we can work in non-traditional clinic spaces, and so things like schools and even outside events, but also homeless shelters, which we'll talk a little bit about today.
And my name is Summer Worrall. I'm the Chief Financial Officer at Hope Christian Health Center. I've been working alongside Myles for a few years now and developing these initiatives that we're going to talk about today. Our focus today is integrating recuperative care and street medicine initiatives. And that population that we're discussing today are those experiencing homelessness. We will likely use some terms interchangeably, whether that be homeless, unhoused, people experiencing homelessness, but just know that this is their circumstance. It's not their definition, and sometimes I think we can make that a definition, but it's just something that is their circumstance, whether that be a season or years, but it's still only the circumstance that they're experiencing right now. And so I would like to ask a question of who encounters unhoused people within your clinic setting? Yeah, most people. Knowing that they have special needs, different needs as different than housed individuals, does anyone have a current plan in place and how you're serving that unique population? Yes? Maybe? Thinking about it. Maybe that's why you're here today. So knowing that we're going to encounter individuals with special, unique needs, we should be preparing our hearts and our minds of how we can meet those needs. So
we'll start off. I'd like to just share a little bit about kind of why Hope exists. Hope Christian Health Center began in 2014 as an FQHC, as I said, but the idea of that started in 2013, and really it was birthed from this group of physicians. In fact, one of them is in the room right now, Dr. Zimmerman. We're thankful that he's here. But a group of physicians that lived in Las Vegas and were going on mission, medical mission trips to Haiti. And as they were going, they were becoming aware of the poverty and the challenges that the people there faced, the health disparities that they would see within that population. And so their heart was moved towards that, to serve those people who are in need. But whenever they came back to Las Vegas, as they're debriefing, they recognized that really it wasn't too far removed from themselves, and really they could look out their back door and be able to see just the poverty, the helplessness, the hurting that surrounds the Las Vegas communities. And so it really just grew this heart and this mind of, hey, what can we do as a people to really make sure that we're being the hands and feet of Christ in the most difficult places and for those who are hurting and in distress. And it reminded me of a verse in Matthew. This verse is just really powerful in my own life and my own journey. But I think that we see a lot of these characteristics here. And in Matthew 9:36 and 38, Jesus was in a position where he had just fed 5,000 people, and he's standing with his disciples. And it says that Jesus looked out, it says he saw the crowds, and he had compassion for them because they were harassed and helpless, like sheep without a shepherd. Then he said to his disciples, "The harvest is plentiful, but the laborers are few. Therefore pray earnestly to the Lord of the harvest to send out laborers into his harvest." And so I love the verbiage here, and I just want to highlight a few of these phrases, but I think that there's an order and a specific nature in which Jesus goes about this recognition and action towards these group of people. And the first thing that he does is he sees the crowd. Said he looked out and he saw the crowd. And I think that this is important and it's vital, even as we look back to Mr. Stevenson's presentation, that we have to have proximity. We have to open our eyes to be able to see the broken and the lost that are around us. I think it's easy to distance ourselves from what's uncomfortable. It's easy to distance ourselves and hide ourselves from being able to see the brokenness around us. But Jesus doesn't do that. He sees the crowds for where they're at. And then it says he has compassion on them. And so because of the awareness that he had a movement in his heart, a movement in his spirits that gave him compassion towards these people, these people who were broken, these people who were helpless, who were harassed. And I think honestly, even as I view that, I think about the homeless people that I see on a regular basis. And they're really not removed from that. They're helpless, they're hurting, they're harassed, they're marginalized. And then I love this, that Jesus' first action is to pray. And I think that's where we have to start as people. I think there was a lot of prayer as Dr. Zimmerman and the others were thinking through this idea of beginning a clinic to serve the neediest. But we must pray to God. And then right after this, at the beginning of Matthew 10, Jesus lays out his plan to his disciples, and he sends them out in order to begin the ministry that they would have before them. And so there's also an action portion of that. That we first have to see the brokenness, that we have to be moved towards a compassion. And we need to pray towards God to equip us and then move and act towards that calling.
And so while we're looking at this scripture, and we are still in 2014, this group of physicians who are moved to begin Hope, we're going to look into developing Hope's why. Why? What is the mission that they developed? And really the foundation of all of our yeses, of why we say yes and when we say yes and when it's appropriate to say yes. And so Hope Christian Health Center's mission statement is to glorify God as we demonstrate Christ's love to the Las Vegas community by providing excellent, affordable care to everyone, regardless of their ability to pay. And so whenever we're, whenever we're looking at opportunities and why, when we say yes, we look to our mission and say, first and foremost, is this going to demonstrate Christ's love? And if it says yes, then okay, what are we doing next? We're providing excellent care. Are we providing affordable care? Is this access to everyone? And when we mean everyone, we're talking about the marginalized community. We're talking about those who are overlooked. That means everyone. And then their ability, reducing is regardless of their ability for pay. We're going to look at transportation. We're going to look at medication, regardless of those abilities. And so whenever we're looking at our yes, of when we say yes, our mission is our foundation of do we say yes and when is that appropriate? Yeah. Oh, that's me. And so as we're looking forward, we're laying the foundation. It is not lost on us that Hope has had God's favor. That in the midst of the trials, especially in the early days, God had favor on us. God had favor on Hope. And in 2018, we began to deepen those roots. And by deepening those roots, God was sending employees who were faithful. They were faithful Christians to carry out the mission, carry out that foundation of why we say yes. So those roots were deepened in our mission with the leadership. We developed a leadership team in 2018 and really started to get down in the nitty-gritty of why. And so recognizing that God still is giving us those opportunities. And so in 2020, 2021, we expanded. There's also a big P word here of pandemic, but we like to focus on the expansion, given those opportunities. And so we expanded. I'm not going to lie, there was some hard challenges in 2020, especially as the CFO there. I was in a bit of a little denial where I'm just like, all right, okay, Lord, let's see some opportunity here. We really are struggling right now. And I know that was among a lot of the healthcare centers. And I remember waking up one morning and I was going to call my boss. I was ready to develop an ABC plan of what we were going to do. I wasn't sure what we were going to do. I was going to start to develop that to figure out how are we going to move forward and to how can we glorify God. And before I could do that, my boss called me and he said, Summer, we got money from HRSA. And I cried. I legit cried because I was so ready to give that plan. And God's favor on hope, that's what happened. He called me and said, we got money. And I think what was different for us was that we did not settle. We didn't take a deep breath and just have a sigh of relief. And we were like, okay, let's just skate through, let's skate by. Hope still stirred in us. God still stirred in us to say, let's go and still serve. We have to go serve the ones who were most affected by the pandemic, most affected by this. And so what did we do? We began to develop an outreach team. We began to go, we partnered with a mobile unit and we started to go out and we met people wherever they were at. We'd never closed our doors, thankfully, thankful to the money, but also thankful to God and God's favor. We also knew that whenever the school started to reopen, they were requiring vaccines on a more stringent basis. And so we made sure that we provided vaccines to children. We started providing primary care at those schools whenever we had those vaccines there. We extended it to their families whenever they asked that. And then we also had the opportunity to expand to our courtyard, which Myles is going to talk about.
And so we tell you all of that because I just think it's important groundwork to before we kind of share where we came to, just to recognize God's favor through all of that and the preparation, the seeds that God was already laying within our team, but then also through just provisions with finances in order to be able to accomplish these things. But in 2020, there is a courtyard homeless resource center in Las Vegas, and this is a city-ran facility. It's a facility where the city is providing resources, things like case management. But in 2020, it looked very different than it does today. And in 2020, there was a very limited case management staff. There was no medical team significantly on site. They had like a 1 half day a week kind of telemedicine type thing that just wasn't really meeting a need. And what they started to see is that ambulance calls to the area were just in a very, very high volume. Do any of you know, like where the city where you're from, where the highest traffic is as far as the station? So the fire station that has the majority of the traffic and emergency calls. Is anybody aware of that? So some of you may be, but I would encourage you whenever you go back, try to ask around and try to figure that out, because as we started to realize the fire station, Station 1 in Las Vegas, that's right near the homeless corridor in Las Vegas, has, I think, the second highest traffic in the entire nation. And so they were seeing 10 to 20 ambulance calls a day for things that weren't necessary. Many of us are medical professionals, are training to be, and so we know that there's a lot of abuse of the medical system when it comes to ambulance calls and the response that has to go. So thousands and thousands of dollars are wasted in those efforts, and it really doesn't bring about the desired outcome that's needed anyway. But the city started to recognize this, and they wanted to do something about it. And so that's when they started reaching out. They're reaching out to FQHCs and saying, is there anybody who's willing? Is there anybody who's willing to come into this space and help us provide health care to this population? Because there's a problem, and we think that you could help fix it. And so they asked a couple of FQHCs in the area. They got a no, they got a sure, we'll try, and then that didn't really work out. And then they asked Hope Christian Health Center. And if you saw Steve Flores's talk yesterday, you know that he said yes. And so we started to develop a plan, had this outreach team that kind of had everything that we needed in these totes, and we had a massage table that we would carry into these places in order to do exams. And we said, you know what, we have this skeleton here. Let's try to do this. And so let's step out in faith into this. And so we're going to fast forward to January 2023, and we've seen ambulance calls reduced from that 10 to 20 to around 2 a day. Depending on the day, I mean, that's going to give or take some, but we've seen a reduction in that. We've also seen that the city has been able to expand what they've done there, and now instead of an area, a dirt lot that people were sleeping on, 200 to 400 people a day. Now it's up to 600 to 800 people a night that stay within this shelter that the city's providing care for. And then they have a much more robust case management aspect as well. And so there's just a lot of services that are centralized here, and we've seen a lot of the homeless community start to congregate there and really start to see this place as home, I guess. Not that you would want them to sit there, but be able to recognize that they're really getting the help that they need within these facilities. And so, and a lot of that, especially the fact that the ambulance calls are down, is very much so in contribution to what Hope has been able to provide within that space. And so I do want to talk about just kind of the organization of the Courtyard medical team, at least. I am kind of was the lead in that. We started out as 2 half days a week, and we're going there just trying to start some primary care, get patients their medications, and now we're up to 6 days a week for the 8-hour days, and then we have a street team there, which I'll talk about in a second, that is there 7 days a week for 10 hours a day. But we offer primary care, and I could sit here and I could tell you, we do labs and we prescribe medications and all these things. But what I think is really important, especially whenever you're dealing with these marginalized communities, is that you have to form relationships with these patients. I see on a regular basis patients that come to me time and time again and talk to me about the reality that they are marginalized by even the healthcare professionals that they interact with. That they're constantly going into hospital systems and going into other clinics where they are ostracized from those communities. Things like a patient who we sent for a chest x-ray because she was having some kind of a lung condition that wasn't responding to conservative treatment, and whenever we sent her to the x-ray facility, didn't even feel comfortable waiting in the waiting room to be able to be pulled back to get the x-ray because people were staring at her, because they were giving her forms and not realizing that she didn't have the health literacy to be able to fill out those forms. And so it's the connections that we make within those settings that is so vitally important, especially at the primary care level. And primary care is all about relationships, but whenever you're dealing with people who have a distrust and a wall built up already, not only because of the trauma that they've experienced from the medical system, but also because of psychosis and psychological issues, substance abuse, all of those things are building up barriers between you and your patients. And it's something that I'm really thankful that we have medical providers that are willing to go into that space and form those relationships so they can build off of that. We also have a street team, and so the clinic space is within that shelter, and so we have a small, very, very small area that we utilize for patient care. But we also have street team members, and so this is made up of community paramedics that we partner with. But we've also hired RNs and EMTs that are literally the extension of that primary care into those communities. And so these are individuals that are walking out among this courtyard and up on the homeless corridor where the tents are in order to be able to form those relationships. And it's great because, again, they're forming these relationships, and so they're with it enough to be able to walk past and say, "Hey, Mary, you don't look right today. There's something wrong with you. You don't look the same like you normally look. You're not walking quite the same. What's going on with you? And how can I help with that?" And then they're able to triage that patient right there, even if it's a distance away from the clinic, and able to find out, is this something we can handle, just be able to give some over-the-counter medicine, some comfort, some education, or do we need to bring in a primary care or even get to the hospital when needed? And so they're able to enact emergency response. I love our team. I could brag about them all day. We've had babies delivered on the streets, literally. We've also had people who have needed emergency resuscitation and basic life support immediately in the interim while we're waiting on EMS. And so this team is just, they're rock stars. They're people who are on a day-to-day basis are just really seeking after the health and community health of that population. We also, I love talking about this because we came in the first few days that I was in clinic. I do what I do every time I do a visit, and I'm talking to the patients, I'm diagnosing, and then I'm deciding, hey, you really need these treatments. These are some things that you need in order to care for your leg wound, in order to care for your hypertension so you don't have a stroke. And then I would ask, like I do at the end of every visit, hey, where do you want me to send your prescriptions to? And then the blank stare that comes back of, well, I don't know, where's the nearest pharmacy? And so I'd Google map it and say, oh, well, there's a CVS about a mile and a half down the road. And they were like, okay, well, can you tell me how to get there? I don't even know how to get there. And so just the access to prescriptions was just a major need that I didn't realize was a challenge for this population. And so as we pivoted, as we adjusted, starting to develop ways that we could intervene and be able to bridge that gap between those patients and the medication that they so desperately need in order to receive the care that they need. And so we've been able to partner with 340B pharmacies, ASP, and provide those prescriptions free of cost to the clients. And so that's something that, again, is just providing access to those patients that they wouldn't have otherwise. Also, many of them do need specialists. We have patients with urostomies that are in the streets walking around. And so that patient needs a urologist, and they need to be able to follow up with that. Many other conditions, as I'm sure you're aware, we have dialysis patients that need transportation to their dialysis appointments on a regular basis. And so recognizing that these people have that barrier of transportation, wanting to bridge that gap, we developed a transportation team, and we have a full-time driver that can transport those members to and from their appointments so that they can receive those care. And I'm happy to say one of the things we're proud about is that we have achieved 50% of the referrals that we make actually get completed, where that patient does get to go to that specialist and completes that visit with them. And we talk about it so oftentimes at our clinic, but that's really higher than our privately insured patients. It's higher than the people in our clinic because most of them don't follow through with that. But we're excited to say that we're bridging that gap for them. And so, yeah, but you'll talk about.
Yeah. Well, so, and as we're talking about Courtyard, as we're talking about all the services that existing at Courtyard, we're still recognizing that there's still some needs. There's still needs there that are still being met. Just this past week, There was 50% of the patients that Myles saw either were admitted to the hospital or admitted to the Recuperative Care Center, which we're going to discuss today. And so that really goes to show of the need of just beyond the need of primary care. That is being provided, but beyond the street medicine that is being provided there was still a need there, that there were still medically fragile and vulnerable individuals that are still within Courtyard that are not safely living there, that they still need medical care. Having unsafe discharges from the hospital to the Courtyard, having a surgery and having a broken ankle and having it repaired and being discharged 2 days later to go to the Courtyard to not rest and recover. And so also having frequent hospital readmissions for that same injury or illness because now they're back on the streets, now they're trying to walk around whenever they should be resting in their bed, and so having a difficult environment for healing. It's not a glamorous environment that they live in, and so we recognize that. And we recognize that there was still a need that need to be met. And so thankfully, the city of Las Vegas asked for an opportunity, asked a couple other organizations before us. However, we were the ones to grab it and say, you know what, these patients have a need and this aligns with our mission, this aligns with our foundation. And we are saying yes. And so what this is so it became a recuperative care center. What this recuperative care center is a 24-hour medical facility. It has 42 beds, and it provides a healthy and stable living environment for those who are experiencing homelessness. And so we're thinking of this as their home. Whenever we're going into a recuperative care center, think of this as your home. And so we're responding to that need, needing a stable environment to rest and recover for those experiencing homelessness. They're too well to stay in the hospital, but they're too ill to go back to their environment that they're living in that circumstance. And so This is the first recuperative care center in the state of Nevada. It's pretty innovative. So a lot of learning, a lot of adjustments, a lot of messiness, I'd have to say, for the lack of better words. And so whenever we're thinking about us in this room, those who are housed, whenever we're discharged from surgery or a hospital, we have a place to go home, right? We have a bed to sleep in. We have someone to care for us, either a family or a friend, and we're allowed to rest and recover. We have someone helping us get food, and that's not the case for these individuals. And so this is what Recuperative Care Center is. And so I'm going to talk about some components of recuperative care. And so the admission referrals. The couple criteria is, first and foremost, you have to be experiencing homelessness. You have and must be willing to participate in the program and its requirements. The requirements being no weapons, no drugs, and your personal property would be stored outside in a bin until upon discharge. Also requirements to be willing to listen to the medical professionals. Sometimes people are not willing to participate in the program and live and stay in this stable environment and listen to the directions of medical professionals. And so that would not be eligible to join, to be a part of the recuperative care. Some of the referral locations that we have are the courtyard and the street med team that we have within there. And another big referral is hospitals. We're still in the process of developing that relationship with them. But the biggest thing is continuity of care here. Whenever we're seeing a person in courtyard or on the street that should not be living on the streets, they should be recovering in a recuperative care. That's whenever they become admitted into the RCC, and also for a hospital if they just need a place to rest and recover from that injury or illness. Some medical services that we provide here are primary care services. The standard primary care services that we're looking at, it's to have continued care to assess whenever they're ready for discharge and to manage their progress. Another service is hospice care, those who are terminally ill. I think of a time in my own personal life whenever I was caring for my grandma, the one who raised me, and in the last days of her life, I cared for her, along with a few of my other family members. I was the one to stay by her side. I prayed with her. I helped her with food. I remember one of the last meals that she had, I picked beets from her garden. It was one of the last beets that we had there. And that was one of her most favorite meals, and I made that for her, one of her last days. And so also whenever it can be very uncomfortable in the last days of your life, and so advocate for those medications. They were giving us the wrong medications. It was supposed to be, a liquid form, but they gave us a pill form, and it just became, we were her advocate for that. And so these individuals don't have that. There are people who die on the street on a daily basis whenever they should be in hospice care. They should have dignity to pass in peace with people around him who care about them and care for them. And so that's something that we really I wouldn't say pride ourselves, but I would say that's something that it's an essential need for those individuals, and thankful for that opportunity. And so another service that we provide are wound care services. A little aside from primary care services, you see wound care being a very prevalent type of injury, I guess, in this population. And so that's something that we do a few days a week at Recuperative Care. We have a clinical pharmacist on staff to manage medications and also provide education for those medications that they're taking, to be able to take them appropriately and know why they're taking them. That's very important, educating them. And lastly, transportation. We also are providing transportation very similarly to the courtyard setting to referrals, specialty referrals, but also whenever they lost their ID, they need their ID. Maybe they need to go to the Social Security office, or anything it will help them become back on their feet. That's something that we provide those services for. So another service is we provide is case management. Case management whenever they're within RCC. We provide insurance enrollment if they're eligible. And so our very proud moment of this is our SOAR practitioner. So what they do is they advocate for the patient. They fill out applications on behalf of the patient to the Social Security office, to the disability office. And having a SOAR practitioner to advocate for you, you receive faster approval ratings, you get higher compensation per person, and receiving those monthly incremental payments are really important whenever it comes to upon discharge. You have a stable income because that is a part of our needs. We need income to overcome homelessness. And discharge placement, we place those individuals with safe housing discharges, greater than 50%. Just in January, we discharged 79% of those individuals to some sort of housing, whether that be transitional housing. And that is amazing. It really is, because we think of like 79% of those are now in housing. They're not in the courtyard anymore. And so we'll talk about some of those challenges, but that is still quite an accomplishment that I feel like 79% of our people are finding places to stay. So thank you. We also provide social support. Social support for financial literacy. We're thinking of whenever they're there 24/7, right? They need other things besides medical. What do we do on a daily basis? We're educating ourselves, we're learning about finances, we're doing things, and so we're trying to provide that stable support, social support, whenever it comes to financial literacy. We have a library that has books and games that they can participate in. Sometimes we have outside meal coordination to sort of feel like it's normal, it's not just this 3 meals coming in. I mean, we might get Chick-fil-A or something like that provide that outside meal, that satisfaction. They also have social gatherings, and we provide a safe environment and security for them, that they can feel safe and secure, which is not something that is guaranteed or even really expected at a courtyard or other setting. And the last one is administrative needs. Again, we're thinking of this as their home. Whenever we think of our home, we think of, do we have meals? We have nutritious meals we provide. There's clean food, clean linens and clothing. We provide that. They have a shower and a bathroom to use. They have a restful environment. I think that is huge for this population, is even whenever they're sleeping in the courtyard, it's not a super restful environment. You're still among 600 to 800 people on a nightly basis, inches away from one another on a mat. That's not super restful. And so providing that restful environment for them to recover. Having access to the internet. We're all internet people, right? I mean, having access to the internet is important. We're human. And also providing mail services. So, yeah. We're going to talk about some challenges.
Yeah, so we've talked about kind of the way that Hope has been able to get into these spheres, both in the clinic setting within the Homeless Resource Center, but also through the Recuperative Care Center. But there also is many challenges that come with that. It'd be easy for me to just get up here and talk about all the great things, but it's hard. It's not an easy feat, and it's something that we oftentimes will just get discouraged with even. And so part of that challenge is the development process of this. Just as Summer had said, that we're the first recuperative care center in the state of Nevada, and so this is not a common thing in even the nation, but definitely in our state, and being able to work towards that is a challenge. But we've dealt with a lot of inexperience, as I was even mentioning with the pharmacy, and just kind of recognizing, hey, I didn't realize that this was a need that they had, and so having to adjust and pivot of it ourselves. We also have unforeseen outcomes. So one of the initiatives that we kind of started working towards is recognizing some of those medically vulnerable people that are within that community, and we started to really push them towards a kind of a fast track towards getting temporary housing. And so we worked with case management. We were excited about this because we were getting those people who really needed a place to be able to care for themselves in those into homes. But the problem with that is that it had this unexpected outcome that as we were sending them out into these places, these are the medically vulnerable people, we were sending them onto these islands. And so we'd send them out to these hotel suites where they would now have a roof over their head, but they no longer had the access to the medical team that was checking in on them daily, that street team that was walking past them and making sure they were okay. They didn't have access to those medications, to those specialist referrals that they would have had even if they would have stayed within the homelessness. And that's not saying that one is better than the other. It's just saying there's that outcome that we didn't expect to happen. And now we're trying to look at, even as a clinic, how we can get into those spaces now and meet those needs even whenever they're outside of the courtyard space and the homeless corridor. But it's also just innovative. It's something that all of these things are new and challenging, and we face that on a daily basis. Adjusting.
So with any innovative, if you have created any new models, it's a whole lot of work, a whole lot of unknowns, and a lot of challenges. And I'm thankful for the resources that we do have for this. However, our population is unique. Our city is unique to the needs that they have. And so whenever it comes to innovations, there are also limitations, right? Funding. I'll put my CFO hat on for a second, and funding are limited, especially in general, budgeting limitations. This service, Recuperative Care, is not a federally recognized organization, or federally service, and so this is not federally funded. There's nothing there. There's not enough. There needs to be more awareness of this need, and also to also reduce the cost whenever it comes to insurances, right? And so educating is very important whenever it comes to funding. Educating the hospitals, educating the managed care organizations in your state, and also if we're thinking really big here, we need to educate CMS. And we need to educate those that we're able to bill on a federal level, and so that are some of the challenges that we're having. And thankfully, we have a partnership with the city of Las Vegas. However, we're always keeping our eyes open. How are we going to create sustainable funding for an initiative? That's the first and foremost, is how are we going to create sustainability? A grant doesn't always last forever, and so how are you creating that sustainable revenue? Also, whenever it comes to that is staffing resources. Whenever we're thinking of this big pie in the sky of like, oh, this is what it's going to look like, and this is the job description we're going to create. And then whenever you think of that and what the really day-to-day life is, it might change because it is innovative. You don't know how this is going to pan out exactly. And also, I think is having the heart. That's the biggest thing here is, do you have a heart to glorify God, to serve those who are in need, to serve those who are marginalized? And I think whenever it comes into this staffing challenges in general in this nation and in the world of the Great Resignation, it's a challenge to even find even those that have the heart to serve this community, because it's not glamorous, it's not easy, it's hard. Especially it's hard whenever they're sometimes mean, and it's sometimes because of their own experiences. They've hardened, and finding a way to just really reach them, to unharden their heart, to show them the love of God it takes people, special people, to find that. And spacing limitations. I think sometimes that might be a good problem because we've seen the need, but the space is limited. He said we have 2 small rooms in courtyard for the storage and to see them.
Employees.
And for 10 employees for 2 small rooms to be able to have a break room and storage and an exam room and a lab and all these things, and you're just thinking, whoa, and so space is limited. Even in our 40-bed facility, at times we're busting, we have a wait list. There's a need there. And so having those space limitations is a challenge. It can be a good challenge, but it's still a challenge nonetheless that we still have a patient population that still needs to be served, that hasn't been served yet. in the workplace?
Yeah, we also have workplace challenges. Burnout is an easy word to say. It's a trigger word, but there's staffing fatigue, burnout in this population. Like Summer said, we do like to consider that the majority of the people that we hire do have that heart. But the problem is that even that heart, as you start to pour yourself out over and over and over again, you become burnt out. And so we really have to, as a clinic and as a supporting staff, as administration, get around these people and help to encourage them and put them in places where they can safely continue to serve those that they're serving. It's also a demanding environment. We deal, especially within the courtyard and the street team, we deal with a lot of difficult patients. And so it's not uncommon for our staff to be cussed out, for them to be yelled at by clients. A lot of the people we deal with have mental illness or substance abuse, and so it's a challenging place. And because of that, they come into this place because of all of their past experiences, their trauma that they're bringing in. There's a very uneasiness and an anxiety that they have coming in, and so that oftentimes it extends out onto our staff. I kind of think about this in a way of whenever we walk into a doctor's office, any of us, if we're going to our primary care provider, we're all going to have a little bit of angst that's inside. No matter where we're at, there's a little bit of uncomfortableness because we're out of control, right? We're giving this control over to this provider. But the reality is there's so many things in our life that we still know that, hey, they're going to be solid. We're going to walk back out to our car. We're going to be able to drive to a restaurant, get food, all of those things. They're walking in, if we're at a level 3, they're walking in at a 9 or a 10 every day that they walk into the clinic. And so that is challenging to overcome the constant stress of that, the shifting and the chaos that it can be to be able to serve that patient population. And so it's challenging and a challenging workplace, but still worth the diving in. And so we say all these things not to be discouraging, but to admit that, hey, this entire process have needed God every step of the way. And we've had to rely on God, we've had to use prayer, we've had to depend on Him in every step of the way in order to maintain our sanity, in order to maintain our consistent workspace, in order to serve Him and get into those places.
And I'm reminded of what Myles and I were talking about earlier today, is that sometimes you just feel like you're out there on your own trying to help these individuals. Especially whenever it comes to hospitals or MCOs, you just feel like you're out there on your own, and you're just working so hard. Your small team is working so hard, and so really the fatigue is real, and so overcoming that is a bit of a challenge. And so as we're talking about those challenges, we're going to talk about some developing community partnerships, because we recognize that not only can we need to depend on God because we can't do it alone, but we need partners within the community to also make this sustainable. And so some of the current partners that we have, City of Las Vegas, they have been our #1 partner here. We're also looking at SOAR, our SOAR practitioner, to advocate for our patients for Social Security income. And so also another case management team as well. Some developing partnerships that we are in the beginning stages of are managed care organizations within the state. Whenever we're recognized in hospitals. So those are the two big whenever it comes to financial funding, financial sustainability. Those are the two big ones where those are the ones that they're serving. So why not have a partnership with them, develop that continuity of care while also reducing their costs? At the end of the day, whenever it comes to hospital readmissions, hospital stays, we're talking about a much lower rate on a day-to-day basis for a recuperative care center for them to not be readmitted, for them to truly heal and recover for that injury or illness. And the third one is the shelters for discharge for follow-up care. That's one that Myles had talked about whenever we're great. They have great news. They are out here and they have a house. They're housing. but there's still a need there. They're on an oasis. They're not getting the medical care or transportation or medication needs that they have anymore. And so developing that continuity of care, whether that be go to them as a mobile unit or maybe bring them back. We're still in the beginning stage of developing that partnership. To always still finding ways to say yes to further meet that need. And so always keeping our eyes open. The work is never done. It's how can we better serve and reach them, expand our margins. And so some of the future partnerships that we have we're always keeping our eyes open to are local nonprofits, having the same alignment with serving the marginalized population. And we're talking about the homeless population here, but we're talking about all types of marginalized communities as well. We're talking about the foster care systems. We're talking about imprisonment. We're talking about all those marginalized that are forgotten and treated as insignificant. Those are the ones that we're trying to partner with to expand those margins. And I'm not going to lie, this has been quite messy. And it's still messy. We're still trying to figure it out. I feel like, still in the beginning stages of it all. And so we're still trying to figure it out, knowing that we don't have all the answers. We don't even have the full plan, but we're faithful and we're trusting in God that He has that plan for us. And we know that He has that plan for us. And we're preparing with what we know best at the time. And that's the biggest thing that I feel like we stand firm on. Yeah.
Yeah, and so we, one of the things we recognize is that we are all on this journey of trying to care for the different populations. Even at the beginning, we just asked for a show of hands of who of you are encountering homeless within your clinic spaces. And so it's something that you are encountering, and we know that your journey may look different than ours. You've got to look at your city and your context to figure out how you may be able to bridge those gaps. But I do think that there's some essential takeaways. My pastor likes to say, hey, everybody has a next step. And so these I'm considering kind of everyone's next step. And I hope that these would just encourage you to serve. But the first thing is to depend on God. Just as I mentioned in Matthew 9, the first thing that Jesus does after he has that conviction is he prays. And he asks for God equipping of the saints in order to be sent out. We also have to be ready with our yes. We started as, again, just this skeleton crew. It was myself and an MA and a front desk person that we would go out to these community events and be able to serve. And we had our massage table and these 2 totes. But we would go out and we were ready for that time whenever God would offer us that opportunity. And then we were able to say yes. Ask for help. Again, just as Summer just said, that we all need help with those endeavors that we're doing, and we need God to serve within that. And then we going to pursue those resources, and then be creative. It's not an easy task. We've talked about a lot of the flexibility we've had to have in some of those spaces, and so something that is constantly evolving and constantly something that changes. And then I would just encourage you to bring the gospel with you. Just like that relationship with that patient is important. It's so vital that we take those opportunities to be able to connect with our patients on a spiritual level as well. And so I try to take as many options as the patients would allow to be able to even pray with them, to be able to care for them at a deeper level than just their physical human. One of the ways that we do this is by a foot washing event, and we just had our first one back in November, but we had volunteers from local churches come in, and just for the simple purpose of serving those that were in that homeless community. And so we had 150 homeless people come through this, and they had their feet washed by volunteers. They had them prayed over by these volunteers, and they received new footwear as well as socks and foot supplies like powder and finger or toenail clippers and things of that nature. And so just a wonderfully humbling event to put yourself at the feet of some of these individuals and to be able to just sit with them for a moment, to be able to understand what they live through on a regular basis. Is just powerful, and I think it moved in a lot of ways in those who were volunteering in that way.
I think that so often they're not cared for in such a special way. And so for you to connect, you ask their name. First, usually they're not called by their name that often. And so getting down on their level, looking them in the eye and saying, hi, my name's Summer, what's your name? And caring with intention and caring for them and having a conversation of walking them to the station, sitting them down, taking them off their shoes and washing their feet and asking their name and having a conversation with them and praying for them. That's an experience that they do not have often, if ever, I'm not sure. And so it's such a great experience for them to just see the love of Christ in action. And so that's what I wanted to say. I felt called to say that, so I wanted to say.
We talked about our next steps. I would just encourage you guys to pray. Oh, sorry, I'll speak into this.
Start small.
Pray, start small. Discuss with your leadership. I think it's important to always just have this conversation with the team that's leading your organization and to ask, hey, how can we start to develop those processes, right? We have these people. What does it look like for us to make margin in our life in order to serve them? And we want to be able to be about that change. And then we have a slide of just some helpful resources, some organizations that have really impacted us.
I'd say the National Healthcare for the Homeless. We have Bobby Watson here too. He's with National Healthcare for the Homeless, but his organization really gave me a very good structure on policy and procedure and ways that we can do things. Like I said, every respite, every recuperative care is unique. However, they give some really good principles and foundation of how you can start this. Also, they started the MRC, which is medical respite care, recently, and so that resource has been very helpful. A lot of trainings there, a lot of webinars, and most recently we've been interacting with Street Medicine Institute, and so always trying to find those resources out there. You don't have to reinvent the wheel. You can just be innovative into your community with the tools that you have. So here's some of our contact information if you would like to contact us directly, and so we'll just open the floor for any questions. Oh. Thank you.
I have a couple questions. I'll try to wrap into one. What does your overnight staff look like on the recuperative care model, and what does practitioner call coverage look like?
Nice. Yes, so the question was, what does the overnight structure look like for recuperative care? Because it is a 24-hour facility. And so there are 2 nurses that are on duty at all times to be able to care for those medical needs. And then they, I believe, have 2 CNAs every night as well that are serving them. The call structure for providers, whenever they work the day, because we have a provider there 6 days a week, but whenever they serve, they're on call that evening and that night. And so they rotate call through them, and then there's other times when other providers may jump in to have call as well.
Average on call though. What would you say? Average call.
Oh, as far as volume, we probably get, it started out, whenever we first took it over, there were a lot of calls. The nurses had many questions, but once we started to establish and equip them in ways, we were able to reduce that to where now they probably call the provider twice a week maybe. And for small things, not that they would have to go in, but just be able to answer those questions over the phone. That help answer that? I think we had a question in the back. Mm-hmm.
And so especially when you just get squared at like 6 times in a row, I know I can go back to God. But I'm just wondering from your experience over the years, like how do you guys handle that practically? Do you really eat together with the staff, or just kind of like hold for you guys to work with that?
That's a good question. She asked how we would manage, how do we practically manage staff burnout? And really, we try to point our staff towards God on a regular basis with that. Meeting as a staff and praying every morning before we set out, just to focus all of our minds and recognize that we need His strength and we need His provision, we need His patience, we need all of those things from Him before we're ever equipped to be able to step out. And then we try to relieve each other, right? So there's moments whenever, like you said, you'll have 4 patients situations in a row, and these people are vicious towards you, and it's not you, they're just angry about a circumstance. And so being able to then recognize that as a team and say, hey, let's come and let's remove yourself, let's sit down, let's take a breather, drink some water, those kind of things. I'm reminded of a story of the prophet Elisha whenever he was just depressed and in distress, and he's sitting under a tree and he's like, God, would you just take me? And there's days where I go home and I feel like that. I'm just like, God, there's just too much. The weight is too much. But God sends an angel to him and he says, hey, get some water, get some food, and get some rest. And then he takes a nap. He wakes up, get some food, get some rest, take another nap. And then he sends him out on his mission again. And so I think we can practically look at that and say, hey, there's times whenever we just remove ourselves from the situation. We need to refocus, pray to God, depend on him in the circumstance, and then move forward.
I think we're always trying to look for ways for burnout because it's real, especially within the healthcare community, but especially whenever we're serving homeless individuals. And so some ideas that we've been having, we're really trying to refocus into God, making sure that is very intentional whenever it comes to weekly prayers. Also, we're implementing a weekly Bible study, but also I think to get out of the clinic, and we're planning a picnic here soon, and so trying to just get away from the setting to enjoy one another on a more real basis, that we don't have to always be in the clinic and have a work setting. So I think trying to get more creative ways outside of what that is, because God is definitely at the forefront and the most important, but it's also nice to focus outward as well of what else are we going to do together that doesn't have the clinic at the forefront. Yeah. A challenge nonetheless. Yes?
I'm curious, so as you guys have done this initiative, what percentage of folks' total services are now these services specifically to the unhoused population? And kind of do you have like a forward thinking on that as you think about chronic care management, now that you're kind of solving crises and follow up for these patients and stuff? What do you think that looks like for your organization going forward?
Yeah, I'll speak. Yeah, and so that's a great question. It's something that again is constantly trying to evolve. It's difficult to get into those spaces and do things like prevention care, and I think that's kind of what you're talking about. We are able to fortunately now bridge the gap where we are getting some of those medicational prevention care, but things like colonoscopies and mammograms are difficult. So what part of the developing partners is also we're desiring and seeking out different mammo vans that can come and have we also provide women's health days. So on Wednesdays, we try to encourage that day to be dedicated, or at least a portion of that day to be dedicated towards women's health. And so bringing them in and being able to do the pap smears and things of that nature on site, but then also partnering with things like mammograms that can pull there. We have a few, not everybody wants to do colonoscopies, but the ones that we can have that conversation with and they are willing, we actually coordinate with Recuperative Care Center to be able to transfer them into that environment to do their prep and their post-op recovery, just so they're in that safe place during the before and after of that procedure. And so there are just kind of the remnants of that early on. Sometimes it does seem like we're much more an urgent care than we are a primary care, but we really try to ground ourselves still and trying to meet those long-term needs.
Have you guys found that this initiative is kind of taking over? The first part of my question, sorry, it's two parts, but what percentage now are you guys doing this?
Asking what percentage of homeless care. Whenever we're looking at a budget, it's about 50%. Recuperative care and courtyard. I would say whenever we first started out, the percentage of income, aside from grants, we're talking about program like patient income. I'm thinking about 20 to 30%. I think we're teetering about, whenever it comes to number of patients, we see about 40% right now. And so that it's just a learning process whenever it comes to that, because we're thinking of 24/7 medical facility, right? So 24/7 medical staff, but we're not 24/7 primary care services. So we're not receiving so we're roughly seeing about the same amount of patients on a daily basis, but we're having 24/7 care. And so trying to find that balance as well. So yeah, we're teetering closer to making it more in alignment of what the budget is, but that's just a challenge in itself. So I'm really hoping the financial partnerships will help close that gap. Oh, lots of questions. Yes, either, any, sure.
This is just a practical question. How do you handle medical records with the street medicine part of it? Because often street medicine is episodic care, which is
Yeah, so and a lot of times you don't even get full demographics on some of those patients. And so we have triage forms, paper forms that we will receive and then file on those patients. We also have a community portal, HMIS, which is, helps to track homeless individuals through different programs in the city, and that we can report onto, not the details, the HIPAA compliant things are hidden from the majority of users, but is able to be seen by our team, and so we can store those documents on there. But it's mostly paper and kind of just a triage form.
And is that triage form incorporated into your medical record at both times, or is it?
We will scan it in if they're a patient of ours, but if they're not, some of these haven't established in primary care, and so that we just have to keep on file. Yeah.
How do you handle like medical liability now as like starting off as a patient record, outpatient record care stuff, now we're doing like this long-term care, like whatever we want to phrase this, like how are you doing that liability?
So it is, so under FTCA, we have just malpractice insurance. We also have supplemental malpractice insurance. Whenever it comes to supplemental malpractice insurance, it's considered transitional care. And so that's what it's classified under insurance. Did you have a question?
Yeah, with the recuperative care, obviously you guys see a lot of different issues. So I was wondering if you guys have found an issue of is it difficult maybe to triage in a particular day with limited beds, who actually needs, how do you guys handle that versus maybe someone can't get in just because of a limited space?
Yeah. Oh, yes. So he was asking how do we handle situations where we can't get patients to the recuperative care center and because they're full or whatnot, and we have to prioritize those that we send. That's a very common thing, and we have to. That's what we do. We triage medically, and we find those most vulnerable and most at risk, and we get those to recuperative care center. And then that's also whenever we reconsider. Okay, maybe this patient needs to go to the hospital because of the severity of their illness, and then this other one who's more stable but also needs a place to stay, we would get them into recuperative care center. We also, because we work closely with the recuperative care center staff, we can make them aware of those patients, and then sometimes they can look at their pool of patients and say, hey, really this person's just so close. I think they're going to be in a place where we could discharge them in the next 6 hours or so. And so we really try to accommodate that as much as possible.
And sometimes whenever it comes, it's I know that we had 40, and we had all the beds full, and we had 6 on the wait list, and that's real. That's whenever it comes to the need. We're not. There's just such a great need. And they do prioritize courtyard over the hospital. You said?
Yeah, over the hospital. So they prioritize any referrals coming from the courtyard because they're coming off of the street as opposed to within a medical system where they are being cared for. And so they make that priority.
I also, something related to that too, is that we do want to prioritize to transition into housing. And so sometimes if there's not a housing placement available, sometimes they will stay a little bit longer at the recuperative care so they can be placed in a home. And so that's definitely a challenge that I'm seeing in my head, the beginning stages of a challenge of how can we overcome that challenge? Can we place them in a more less 24/7 medical facility, maybe just in a transitional home to place them somewhere else eventually, to be able to fill that bed to someone who medically needs it. So.
We'd
Yeah.
love to answer more questions, but
Yeah.
we're over time now, so we'll let everybody go.
Thank you. Yeah, or definitely, can stick around if you want.